Thank you, Dr. Ajapal, for the kind introduction, and it's an honor to be in your course. In the next few minutes, I'm going to discuss about traumatic and intraoperative ectopia lentis. Well, we all know that ectopia lentis is defined as displacement or malposition of the crystalline lens of the eye, and the commonest cause being trauma. Well, all we are going to discuss about the management here is the basic goal is to restore as much normalcy as possible and to look at long-term results, because this generally happens in younger age group, more in the younger age group. Well, let us start with this traumatic one, a blunt trauma. The whole clear crystalline lens is dislocated in the anterior chamber, and as you can see, there is vitreous because the pupil is dilated and it has been there for some time. So my approach was to make a scleral tunnel, and of course you could have gone through the pars plana route, but that would be appropriate because we would have caused a lot of injury. We would have had to push it back to the vitreous. So it's an anterior vitrectomy to release all the attachment of the vitreous with the lens, and of course, with a wear victis, you can gently take it out, but my calculation was slightly wrong. It's a big rexis, so it's a big nucleus, and so I had to push it gently with a iris repositor, and it comes out. Then I go ahead with further vitrectomy, and as we go, we see there is a small dialysis at 6 o'clock, and thereafter, we manage with lenses. I'll come little in a little while. This is another case. This is a spontaneous dislocation, I would call, because there was no major history of trauma. So the whole, hypermature Morganian cataractus lens was dislocated in the anterior chamber. In a similar way, it was easy to take out because the lens size has reduced. And as we have already discussed, there are few options. In these cases, I prefer a scleral fixating or a retro iris fixation. In this case, of course, this was a routine, scleral fixation by glue, and this is how we all go. The leading haptic to be taken out is to be exteriorized with one of the forceps, and then we take the other haptic out once this is taken out. And I'll go, because of want of time, I'll go here a little fast, and the other haptic is also taken out through the other port. And once that is done, the pupil is small, so we push the optic behind, and then we can tuck the haptics in the preformed scleral tunnels. This is the other way. I use a AC maintainer at times that creates a lot of good comfort in the AC. It maintains the AC, and things become smoother for us. And once the same thing is repeated, a handshake technique to take out the trailing haptic. And once both are out, we go ahead, tuck it in the preformed scleral channel, and then we kind of reposit the flaps and use glue to complete the case, and the peritomy, the conjunctiva is also closed. So this is how we complete this kind of cases. This is just the other kind of lens that I generally prefer in this case. This is fast and simple. Dr. Chitra Ramamurthy has also shown it's a iris clip lens, and it's easy to tuck it behind the iris, and it's very simple, less time consuming, and later on long-term results are pretty good because you can dilate and see the fundus, and the only issue is the pupil size. Maybe initially not so round, but gradually with time it becomes round, and there are no long-term problems as of now. Well, this is another case. This patient, he's a young patient, but had a history of uveitis about 1 year back, but no other history of trauma or anything. So this is a soft nucleus, as you can see. And once the hydro procedures are done, and I found that it's not free, so I thought there must be some corticocapsular adhesions. So mechanically, I tend to kind of rotate and sweep and rotate, first sweep and then rotate. But I feel that I have done it too vigorously, might have injured zonules. This is one point of caution. And here I would like to ask you to see that the bag is wobbling here. It's just floating sometimes. And as you see now, it's still floating. I don't know if you can make out from the quality of the video. And now something has happened. I understand. So I kind of come out and see with I inflate the bag. I want you to see once again, I inflate the bag with, it has all come out with viscoelastic. Now I understand I have a little bit of cortex remaining. So I need to stabilize the bag. I could have done it with a pair of hooks, capsular hooks as well. But I thought, okay, in the long run, I'll have to put a CTR. So I did it at the first go. And after I do it, it's really, I have injured a lot of the zonules there. So now with tangential pull, I can take out the cortex with little difficulty, but it's done. And once this is done, as planned, what I do here is I put a multi-piece foldable IOL, and here I'll go a little fast. It's very easy to put it. What we do is we put the lens in the sulcus, and thereafter very carefully put it in the sulcus and do an optic capture so that the IL remains stable all throughout. Now, this patient is here with 5 years follow-up with us, and he is perfectly fine. The lens is right in position. So that was a real bad intraoperative zonular dialysis that I had created. Now, this is an extreme trauma, again a blunt trauma. This lady is 28 years old, and she presented to us 2 months after this trauma. And as you can see, there is a huge amount of iododialysis as well. So what I planned was again a scleral fixation of IOL with glue. And as you can see, to begin with, I anchored the iris to one side with 2 iris hooks, and then went ahead with vitrectomy. I could use the port 1 millimeters behind because there was no iris, so I could go through there and do vitrectomy, lensectomy. It's very much valid. And once that is done, I go ahead with the glued IOL technique. I'll go a little fast here, and I'll skip this part for want of time. And again, once we tuck the haptics in the preformed channels in the sclera, I go ahead with the repair of the iododialysis. I take away the 2 iris hooks and release the iris from there, and thereafter I start suturing, repairing the iododialysis, and I use all kinds of tricks here to do it. And the simplest one was simplest effective one was to use a slip knot, and which would actually pass to the interior inside, and then we need to cut the knot ends from inside the eye. So that is how it was easily done and very effectively done. So we can use a macro scissor, or okay, if my time is up, I'll just show that we cut the loose ends, and that is how we complete the case here. And the only problem here, the patient is doing fine, but the only problem here is, she has glaucoma, persistent glaucoma, and being controlled with 2 medications. Thank you. Thank you so much for the opportunity.
Thank you, Siddhartha, for showing us those amazing